So welcome. I'm super excited about what we're going to be talking about today. So we're going to take a look at expanding what we know about water. So everyone's got a really solid foundation based on the concept map that I saw last week, and then I was really pleased with what I saw in the pattern of inquiry. So we're going to take this and dive a little bit deeper. So we're going to expand what we know about water this week. So I want you to take a moment and tell me what you see in these three images. What do you notice?
Water isn't penetrating them.
Mm-hmm. Right. So there's water on a surface. What else do you notice about the water on the surface, specifically relative to the charge?
It's sticking to
Mm-hmm.
the red is sticking to the positive and the white is sticking to the negative.
Yeah, right. There's an orientation to the way water kind of organizes itself. And you can see that both around individual ions. So in the case of a mineral like a salt, you can see the organization of the negative relative, right, to the positive charge. And you can actually see kind of like a casing is a good way of describing it, where the water molecules are so organized that they surround or encapsulate the ions, which looks a little bit different, say, for example, than a metal or a biomembrane. So, part of what we're going to be talking about today is what is affectionately known as solvation shells or solvation sheaths. So, these are going to occur really at the interface of any of the chemical compounds that we consider solutes. So, if our solvent is water, then we often refer to it as a hydration shell or a hydration sphere. And it's water functioning as a solvent to surround that solute. And you can actually see that here by thinking about what we talked about last week, which was the partial positive and the partial negative charges of a polar molecule like water and the way they orient around ions. So the next kind of piece of this, if we take one step further, right, is to think about the energetic properties of water molecules based on their local environment. So I want you to think about this question. What would you predict about a protein if it's easy to displace a water molecule? So if you could swap out one water molecule for another, they're easy to move. What would you know about the surface of that protein? What do you think you would see?
It's not very charged.
Yeah, right. If it's easy to move a water molecule, it's going to be almost entirely a surface that's carbon hydrogens, right, as opposed to ions or something that's charged. So the really cool part about this, which is just fascinating when you think about macromolecules and their general structures, is you can actually really influence the behavior of biomolecules based on their hydration shells. So whether or not there's a lot of water present or a little bit of water present. And you can see examples of this, say, for example, the way water organizes around DNA or the way water organizes around a globular protein, or in the bottom leftmost example, the way that water organizes around a phospholipid bilayer. So part of our job today is to really start to think about those organizing principles of water and to go a little bit deeper. So, um, whether it's referred to as the hydration shell or a hydration layer really kind of depends upon shell is if it encapsulates something like an ion. Hydration layer would be more common to describe, say, for example, the behavior of water across a phospholipid bilayer. And this piece is really interesting to me. So if we think about the hydration layer around a protein, um, they have been commonly found to have bulk water to a distance of about 1 nanometer outside the surface of that protein, which, when you think about the size of water as a molecule, is staggering, right? There's a lot of water that's organizing around a protein if it's to a distance of 1 nanometer. And then the other piece about this that I think is really interesting is that when you think about the actual duration of contact, um, evidence that we have so far says that it's sub nanosecond range, although the molecular dynamics simulations suggest that there's time that water spends in the shell before it mixes with the outside kind of bulk water, and that could be as fast as femtosecond or picosecond ranges. So when we say what happens at the surface with water, there's a significant range of time or the duration of that contact. Now, it's really important to note here that with other solvents or solutes, you can have varying steric and kinetic factors that can also affect the solvation shell. So this is an aqueous chemistry class, so our focus is thinking about water, but there are definitely other solvents that have varying properties that might change that duration and the properties of the solvation shells themselves. One of the pieces that we're going to use to help us is electronegativity. So we're going to refresh our recollection briefly on how we use electronegativity to identify bond types. So if you take a look here, these are ranges. So the range from 0.0 to 0.4, the range from 0.5 to 0.9, from 1 to 1.3, from 1.4 to 1.7, from 1.8 to 2.2, and then from 2.3 to 3.3. And you'll notice, right, when you're first introduced in general chemistry to intermolecular forces and bond strength, they're usually, well, it's either polar or nonpolar. And that's an oversimplification. The reality is that there is a range based on electronegativity of nonpolar covalent, which is the least difference in electronegativity, all the way up to something that is highly ionic. Um, and you'll notice that there are even differences between the types of ions. So something like an anion-cation relationship that is NaCl, right, is not as highly ionic as something like magnesium oxide. So when we're thinking about the differences in electronegativity, it's really important that we hold that that's a range and that um, the boundaries between, say, for example, something that's nonpolar covalent and something that's slightly polar covalent are squishy, right? The difference between 0.4 and 0.5 is negligible. So you very well might have something that is nonpolar covalent, right, on the upper end here, that might behave more like something that's slightly polar covalent. Now, the reason why it's important to talk about this is because there are two kinds of intermolecular forces that really strongly come into play based on differences in electronegativity. And the first one is dipole-dipole, and the second one is hydrogen bonding. Now, when we talk about ionic interactions, that's a little bit clearer because, right, the interaction of a cation and an anion is very clear and distinct. You can imagine, say, for example, the pKa of an amino acid that allows it to interact as a negatively charged anion versus the pKa of an amino acid that allows it to interact as a positively charged cation at a given pH. But these two are a space where electronegativity is a little bit more malleable. And so the behavior of what makes something a dipole-dipole interaction versus a hydrogen bond is an important distinction. So we're going to make sure that we reference kind of electronegativity for some of our arguments. And to help kind of strengthen our understanding, I want you to think about, right, decreasing strength. So when we're talking about our molecular forces, really it's a force acting at a distance. So there's a sweet spot, a saddle point, if you will, for when you see these types of forces show up, and right for how long they persist depending upon the distance between two atoms. So as we go from left to right, one of the pieces that I want you to be thinking about is the fact that hydrogen bonding is the strongest non-covalent molecular force that molecules experience. Then it's ion dipole or ion induced dipole, then dipole dipole, then pi stacking and cation pi interactions. So if you want to think about it, right, these are our London forces. And these are definitely far weaker. And again, if they're far enough away, they don't experience these forces at all. So when we're talking about hydration and the interaction of, say, for example, water molecules with a surface, we're thinking about intermolecular strength or forces, and we're also thinking about that electronegativity. So those are two key concepts that are going to influence the behavior of water. Okay, so I promised that we would dig a little bit deeper today. So I want you to think about the osmosis and right and what is osmosis. So take a moment, um, refresh your recollection. So osmosis is the spontaneous net movement or diffusion of solvent molecules through a selectively permeable membrane from a region of high water potential to a region of low water potential in the direction that tends to equalize the solute concentrations on the two sides. So it's really important for us to be thinking about, well, how, right? So take a moment, reread that for yourself, and think about how you would say that in your own words. All right, so in your own words, how would you describe osmosis? What do you think?
I was still writing mine down, but I started to say the flow of solvent molecules through semi-permeable membranes from high concentration to high to from high to low
Mm-hmm.
water potential in the direction uh, for the purpose of reaching equilibrium, or
Yeah.
is it homeostasis or
That's a good question. So the reality is, especially when it comes to living organisms, because we have intracellular and extracellular concentrations, it's a dynamic equilibrium is probably the very best way to describe it. And homeostasis is part of how we regulate that. Um, but I think that's a brilliant way of describing this in your own words. So thank you. That's super helpful. For me, sometimes a visual is actually better than the words. And so I have both a plant cell example and an animal cell example. And the goal here was to show the movement of water. So in this case, when something is hypotonic, it's the movement of water into the cell. And so in a plant cell, you can actually see it's turgid or stiff on the outside. For an animal cell, I often think of it as like a balloon that's fully blown up, where the pressure on the inside is exerting um, force so that it seems distended. That's very different than, say, for example, something that's hypertonic, where you have shriveled cells or cells that are um, essentially the water is coming out of the cell, and so the actual volume of the cell itself is decreasing. Now, in a plant cell, we would say that that's plasmolyzed, but again, it's the movement of water out of the cell. And then isotonic is probably the space that folks are most familiar with, and that is really where you have net movement of water both in and out of the cell. And so when we refer to something as isotonic, um, what we're actually saying is not that there's no movement, but that the rate of the movement is into the cell and out of the cell in such a way that we have dynamic equilibrium. So What does all of this mean? Well, our focus today is to be thinking about osmolarity. And so this is the concentration of a solution that's expressed as the total number of solute particles per liter. So last time we looked at different chemicals and their Van Hoff factor. So when, say, for example, glucose goes into solution, it stays as glucose. It does not separate into different particles. It just stays as a single particle. Whereas sodium chloride, when it goes into solution, it actually becomes two ions. So the concentration then, if I had a 1 molar solution of sodium chloride, would be 2 osmoles per liter because there are two particles that are generated from sodium chloride. Similarly, if I looked at sodium sulfate, which was an example we looked at last class, then, right, 1 molar solution of sodium sulfate would actually be 3 osmoles per liter, again, because it's the number of solute particles per liter. So you might be thinking to yourself, well, what does that have to do with osmosis and the movement of water? And that's where we're going to spend a little bit of time thinking today. So the example we're going to use is blood serum. So serum is the fluid and the solute component of blood that does not play a role in clotting. So sometimes folks will refer to this as blood plasma without clotting factors or as blood with all cells and clotting factors removed. Serum is typically the proteins that aren't used in blood clotting. So all electrolytes, antibodies, antigens, sometimes hormones, and any exogenous substance, so drugs, microorganisms, etc. That's what's going to show up in your blood serum. What it does not contain are white blood cells or leukocytes, red blood cells, your erythrocytes, platelets, or clotting factors. So if you think about, well, how do you get blood serum? Right? That process is right an important distinction. So plasma is the liquid that has no cells in the blood. So essentially, it has been centrifuged and treated with anticoagulants. Um, and essentially, what you get, right, are your plasma layer, your liquid layer that's the top. You get your white blood cells and your platelets that are kind of in the middle. And then your red blood cells are at the bottom. So that's your plasma. Serum is the liquid part of the blood that's after coagulation or clotting. So there aren't any clotting factors like fibrinogen that are present in your blood serum. So we're going to look at what is left in the blood serum and what are some of the tests that, say, for example, a hospital would do in a metabolic panel. So in order to do that, this is a really important distinction for us. We have to make sure that we are solid on the difference between osmolarity and osmolality. So osmolality is always the concentration of particles, right, in your serum. So a higher osmolality means that you have more particles. A lower osmolality means that there are fewer particles or it's more dilute. Whereas osmolarity refers to the number of particles of solute per liter of solution. So osmolality is always the mass, so solute per kilogram of solvent in this case, whereas osmolarity is the moles of solute per liter of solution. So that's an important distinction for us. We're going to start by thinking about things you can measure in blood serum. So the anion gap is one example. Sometimes it's referred to as the Ag or the A gap. And this is the difference between primary measured cations like sodium and potassium, and then the primary measured anions, chloride and bicarbonate, in the blood serum. There are two formulations for this. I think this is so fascinating. So the complete equation is the serum anion gap that's shown here. So that's sodium plus potassium minus chloride plus bicarbonate. Uh, However, in a healthcare setting, to simplify the calculations, they remove the potassium and they just use the sodium. Now, the reason for that is that potassium is present in a much smaller amount, so you can get a close approximation by just looking at the sodium. Um, and so we'll actually do a calculation to practice that. Now, you can also use it to differentiate cations and anions in urine as well as the blood. So the urine anion gap is the sodium plus potassium and chloride. So we exclude the bicarbonate from urine. So um, here's some information from a patient who has severe hypoalbuminemia, suffering from a post-op organ failure. And we're going to calculate the anion gap and the albumin corrected gap. So normal albumin and observed albumin are the components that we're going to take a look at. So the first calculation that we're going to do here is, remember, we've got our sodium ions, and then we're going to subtract, oh, sorry, we have our sodium cation, and we're going to subtract our chloride anions and our bicarb anions. So notice these are milli equivalents per liter. As long as these are all the same unit, we know we're okay. So this is 137 minus 102 plus 24. And I get 11. So if we're thinking about the albumin corrected, it's really important for us to think about what's normal and then what's observed. Just double checking my calculation. All right, so we want to correct for albumin. The reason why this is an important thing to do is because albumin is actually a negatively charged protein, and it can contribute to the anion gap. So there are different versions of this, but the simplest version that I have found is your anion gap. So that's what we just calculated. And then plus 0.25, and then we multiply that times 44 minus the albumin. And so we're going to calculate this and take a look at what it is with a normal range and with what it is in this patient's. So we calculated 11. So 11 plus 0.25 times 44. And if it was normal, it would be 4.4. And then you can do the calculation for the one with the observed albumin. So 20.9 is what I get. So you can see, even with normal albumin, why it's important to do a calculation that corrects for the anion gap associated with albumin. Okay. So one of the things that we're going to be doing today is taking a look at a metabolic panel. In order to do so, we are going to need to do a couple of things. So the first thing that we're going to need to do is think about, well, what are all of the components that we're going to be measuring when we look at blood serum? So that's where we're going to head next. In order to do so, I want you to see some relative ranges. So I'm sorry this is a little on the dark side, but I actually pulled this directly from CHOMP and a reference guide that one of the physicians was using. So for sodium, there's a value, right, and a standard range. Notice the units. This is where our understanding of concentration becomes so key because some units are millimole per liter, other units are milligram per deciliter, and we're going to practice calculating back and forth between those. So we have potassium, chloride, carbon dioxide, and glucose. So I'm going to do a practice calculation looking at glucose. So let's say that we had 100 milligrams per deciliter of glucose. So if we look at this, right, this is the range, right? So the patient falls within that range, 100 milligrams per deciliter. But I want to think about that from a chemist perspective, not just a nurse's perspective. So if I'm thinking about this conversion, right, and I wanted to convert my milligrams per deciliter to millimole per liter, how would I do that? So I'm going to do that at the bottom of the page. So this is glucose. And if I'm doing this calculation, right, I have 100, and that's the milligrams. So I know that in order to convert to moles, I need to convert that from milligrams to grams. So I know there are 1,000 milligrams in 1 gram. I'd also need to look up the molar mass of glucose or calculate it using a periodic table. So in this case, the molar mass of glucose is 180.156. And that's grams per 1 mole. Now, this is an important distinction. This is 100 milligrams, right, per deciliter. So that's per 1 dl. And so I know that in 1 liter, there are 10 deciliters. So 10 dl per 1 liter. So when I calculate that, if I take a look at my units, right, my milligrams cancel, my grams cancel, my deciliters cancel, and I'm left with moles per liter. So if I think about that, that's 0.00, oops, sorry. Try that one more time. 0.00555, and that's moles per liter. Now I could obviously convert that to millimoles if I, right, think about the relationship. So there are 1,000 millimoles in 1 mole. So that would be 5.55 millimoles per liter. Okay, so here we have grams per deciliter. And then this IU per liter is, IU is another metric or unit of measure. We'll get to talking about that in just a moment. But this ability to interconvert between concentration units is a highly valuable one to do. Notice some of these have a time component to them or a rate. So if you want to, it's super useful sometimes to be able to think about the conversion within a range with respect to concentration. All right, so I'm going to clear our drawings And now we're going to take a closer look at each of these electrolytes. So I think this is such a fascinating space to explore aqueous chemistry because there are all sorts of reasons for increased and decreased values associated with a given electrolyte. So we're going to orient to this table. So we have a typical reference interval for healthy adults. Now the star note most important um, observation here is these are ranges for a reason. Each individual is going to be unique. And sometimes you can have someone whose baseline level is high or low, even relative to the typical references for healthy adults. So this is a really great example where it's super important to know your own baseline. So when you're at your healthiest as an individual, what are numbers that are normal for you? And then knowing what's outside that range, if, say, for example, someone's feeling sick, can be really important. So um, we're going to take our time and think about each of these. So let's start with sodium. So this is very common, a significant major extracellular cation. If you want to think about it, sodium's responsible for a couple of different things. So it maintains the fluid balance in circulation. So your blood levels or sodium levels are typically controlled through the excretion and the reabsorption by kidneys. And if you want to think about a typical reference interval for healthy adults, somewhere between 136 and 145 millimoles per liter. So let's think about some reasons why you might increase or decrease values. So um, if you're dehydrated, that's going to increase the amount of sodium cation. So the concentration will go up. Um, Diabetes is another reason why you can see an elevated level of sodium. Um, One of the reasons why it can go down is GI loss. So that could be diarrhea or it could be vomiting. But sometimes there are also diseases that can actually cause a loss of sodium, just like there are some diseases like Cushing's that can cause an increase. If we think about another common um, cation, and that would be potassium. So this one is the primary cation that's responsible for muscle contraction, and it's also responsible for maintaining your normal heart rate. Notice the difference in the amount of potassium relative to the amount of sodium. What do you notice?
Sodium is a lot more.
Yeah, right? By a huge magnitude. So sometimes, right, when we're thinking about reference values, it's really important to notice what a normal range is for a given ion. So, potassium is something that we see increases often due to shock, maybe a circulatory failure, um, and again, some aspects of renal disease. And you'll notice again, vomiting and diarrhea are also reasons for a decrease in the amount of potassium. Sometimes there are drugs that are given as diuretics, and that can cause a decrease in potassium. And there are some actual cancers that can also result in a decrease in potassium. So now we're going to take a look at chloride, which is the major anion. And this, right, tends to mirror your sodium concentrations. But notice, right, the amount of chloride is lower, right, than our amount of sodium, but higher than our amount of potassium. And again, you can influence this through dehydration, and sometimes the sodium cation itself can influence this value. The next one we're going to take a look at is carbon dioxide. So CO2 um, is not charged the way we think of a charged species. However, because of its role in the bicarbonate buffer system, it can function as an anion when the proxy is bicarbonate, so HCO3 minus. So you'll notice that there are ways of increasing this through alkalosis and ways of decreasing this through acidosis. And again, that's entirely dependent upon the pH of the blood. So we calculated our anion gap. Our simplified formulation is sodium minus chloride plus bicarbonate. So I want you to think about what that would be in a normal range. So we're going to calculate that value um, using a number from the ranges that are given here. So take a moment, decide what your number between 136 and 145 will be for sodium. Decide what your number for potassium will be. Decide what your number for chloride will be. And then carbon dioxide, in this case, bicarbonate is the anion that we're going to be calculating. You can assume that it's between 22 and 28 milliequivalents. So let's take a moment and practice calculating that anion gap. So I'm going to choose the numbers just for the sake of expediency that are the low end. So these are the numbers that I'm going to use. So I have 136 plus 3.5 minus, I have 98 plus 22. So my anion gap is equal to 136 plus 3.5 minus 98 plus 22. So 19.5. So here's what I want you to think about. This is what they list as the range for the anion gap. But, right, the reality is you're going to see some variation. So what might be reasons why you would see variation in your anion gap? Well, the amount of food that you're eating, so if someone's starving or if there's uncontrolled diabetes or lactic acidosis are all reasons why you could see an increase. Sometimes, say for example, if you have substances, alcohol, salicylates, oxalates, those are also reasons why you could see a change in your anion gap. Okay, so we've looked at major electrolytes. We're going to expand and think about kind of this variation. So really importantly here, a healthy adult and a healthy child may have very different reference values. Um, and if you're thinking about patient populations, as well as the setting, how you assay those values, right, it's going to be really important that you verify and think about a range. Um, so we've talked about electrolytes that are common in blood serum. Now we're going to take a look at ions. So we have calcium, we have phosphorus or phosphate, and then we have magnesium, and we have iron. And part of what I want you to notice here is that um, in terms of each of these, right, there's what it does, its job. So calcium is the mineral that we use for bone formation and for blood clotting, and it actually serves very important functions for nerve and muscles as well. Usually, this is actually a separate test. Calcium is very tightly controlled, and there's a very narrow range. You can actually see that here. Um, and if you have an abnormality, something outside of that range, um, there are any number of problems that could be the cause. So if we think about phosphorus, this too is a mineral that's important for bone, but it's also involved in energy production, say, for example, through ATP and ADP, as well as some nerve and muscle function. So it's not uncommon to measure this with calcium. And again, right, it has some very narrow ranges in terms of what the typical reference values would be. If we think about magnesium, so magnesium is critical for enzymes. Say, for example, a kinase can't function without magnesium, right? So when we're thinking about converting energy to muscle, and actually we have magnesium play a role in bone structure as well. So typically we don't order magnesium initially as part of a panel. It's usually a follow-up if there's something off with the calcium or the phosphate numbers. And then iron is a fascinating ion as well. So hemoglobin, iron is essential for this, as well as myoglobin. And there are a number of pathways that actually also have enzymes that involve iron. Now, in this case, right, iron deficiency or anemia is something that is often tested for using blood serum. Um, and notice here there are ranges for males and females in terms of differences in the relative concentrations, but these also can vary by region and by demographic. So it's really important. There are um, hereditary reasons why there could be differences in terms of iron as well. Okay, we've got some small molecules. So we talked about glucose and what the target fasting value for glucose would be. We also have vitamin B12 and we have folic acid. So these are vitamins that are necessary for functioning. And in the case of folic acid, they're particularly important for the development of a fetus. If you're thinking about why we measure these, so glucose is usually what's used to measure or test for diabetes or for insulin resistance. Vitamin B12 is usually a deficiency that we see associated with iron. Um, and there are some specific types of leukemias where the increase of B12 can signal um, issues with um, the development of cells. And then, unfortunately, B12 is something that's commonly seen in malnutrition environments. Or where there's the inability or malabsorption of that vitamin. Okay, in addition to those components, there are also some waste products that are found in the blood serum. So total bilirubin um, is a breakdown product of hemoglobin that is typically excreted by the liver into the bile. There's both conjugated and unconjugated. And in this case, it's the carboxyl groups that are either free or esterified. Usually, total bilirubin is used to assess liver function. So if someone has hepatitis or cirrhosis or some other type of hemolytic disease, total bilirubin is an indicator of that. Notice here there are a couple of components. So there's direct bilirubin. So this is the conjugated form. There's indirect bilirubin. This is the unconjugated form. And then there's neonatal bilirubin, where the liver has not yet matured. And so bilirubin can actually enter the fatty tissue of the brain and the central nervous system, and that can result in damage. And so it's really important to actually test a newborn for bilirubin to determine whether or not intervention is necessary. So those waste products are also seen in um, the blood. And then we have lactic acid, uric acid, and creatinine. So these are all metabolites or breakdown products. Um, and it's really interesting. We often use lactic acid to determine oxygen delivery. And then uric acid is something that is common for joint inflammation. And then creatinine is one of the other components that are used to measure kidney function. Um, and it's interesting, you can measure this in the blood and the urine or both to be able to determine your kidney function. And again, notice there are specific ranges in this case. And again, I think the caveat here is that these ranges were developed and tested on a narrow population. We probably see much more variation. Okay, last two are the urea or BUN. So this is urea nitrogen. It's a common protein breakdown product that's found from the liver and it's excreted by your kidneys. And then ammonia, so this is a waste product of amino acid breakdown that again is converted to urea by the liver. Um, and when you have um, disorientation or coma in adults, this is actually a common test that's used. I think it's really important here to say that the reference intervals here are sourced from a reliable source. That's the Clinical Diagnosis and Management by Laboratory Methods that's regularly updated. So it does reflect the best data that we have available at the time. And then we have some proteins that are commonly measured in the blood. So we have a total protein count, and then we also have urine protein. Um, Normally, you don't have a lot of protein in the urine. If the protein level is high, then there's an issue with your kidneys. And then the cerebral spinal fluid. So if you have protein there, um, that could signal, say, for example, an infection like meningitis. There are specific proteins that we pay attention to, like albumin and globulins and ferritin. Again, I want you to think about both its purpose in the blood and then how it's measured or why it's measured, and then your reference values, and then why there might be reasons either for increasing or decreasing those values. And then this is the last one. So this is going to depend on the human, but there are immunoglobulins that are really important. They serve a variety of purposes. So IgA, for example, protects your mucous membranes, whereas IgG, which is about 80% of your immunoglobulins, is part of your immune system. Um, IgM is the largest, but often is in response to infection, and IgE is very commonly responsible for allergic reactions. There are enzymes that you can test blood serum for. So ALT or alanine aminotransferase and aspartate aminotransferases. These are indicators again of liver health. Um, you have alkaline phosphatase or ALP. That's commonly found in bone and intestine, kidney and liver tissues. And then we have gamma glutamyltransferase um, and lactate dehydrogenase. And these are examples of enzymes that you are often going to measure in a metabolic panel to indicate different types of diseases. Similarly, we have creatine kinase, amylase, lipase, and pseudocholinesterase or cholinesterase activity. And again, we have reference values for each of these. Um, we often use these to diagnose pancreatitis or gastritis when someone is not feeling well. And then we've got lipids. So your total cholesterol, you're probably familiar with HDL or LDL. So high density lipoprotein and low density lipoprotein. Each of these components are tied to the metabolism of cholesterol and then why we might measure them. So sometimes they're measured generally as part of a cardiovascular profile. Sometimes it's because there's a risk factor associated with coronary artery disease, or sometimes there are associations specifically with dietary impacts. And then there are some that are less familiar. Folks are not as familiar with these. So very low density lipoprotein or VLDL, your triglycerides, your lipoprotein or LPAs that have essentially an extra protein chain that is attached. Apolipoprotein, A1 and apolipoprotein B. These have cardiac risk profiles. Typically, they're a protein that's attached to HDL and VLDL or LDL. Okay, so we just covered a ton of content. I want to make sure that you have time to take a look at um, here we go. Our pattern of inquiry. So let me pull that up and we'll take a look. Okay, so here there are a couple of concentration refresher recollections. So let me make this a little bit bigger so everyone can see. All right, so the first piece of this is just making sure that you're clear on the difference between molarity and molality. So, and we've got a couple of different calculations here. You can use the one that we did for glucose. And then I've asked you to calculate calcium, albumin, blood, urea, nitrogen, and total protein. Um, you're given information, you can do those conversions. Hopefully that will help refresh your recollection. You're welcome to take a look at the citation for these values. And then the next question I want you to think about are the anions and cations that we've been thinking about. So provide examples of hydration shells of each type of ion and try to be accurate with the number of water molecules that surround them. So think about how many water molecules are going to surround a sodium ion. Think about its relative size. Think about how many water molecules are going to surround a chloride ion. What's its relative size? And then the comprehensive metabolic panel is what we were just taking a look at. So that's a really broad screening tool. Um, and it can be used to monitor kind of general health conditions like hypertension or someone who has kidney or liver diseases. But they also are looked at and evaluated kind of holistically or together. So just because there's one abnormal test might mean something very different than if there are multiple test results that are out of range. So choose one of the tests that we haven't taken a look at in depth and think about that range, why it matters, what normal is, and describe that. And then think about, well, what would be abnormal? So if you were to look at a value and see a specific concentration, what would make that test abnormal and why would it be a concern? All right. Number 4 is an analysis. So this is asking you to apply your understanding of the Van Hoff factor and osmolarity. You've got a couple of components of that calculation. And then number 5 is asking you to compare and contrast tonicity, percentage, concentration, density, specific gravity, molarity, osmolality, and osmotic pressure. Those are all jargon for concentration, but we want to really break them down and think about what each of those terms mean. So I'd like you to give an example of the use of each with the correct units, and then what's a context in which you would think about that term. And then the last one is intended to be a visualization. So it's a thought experiment. You can draw it out if sketching it would be helpful. A glass U tube that has sodium chloride solutions that are separated by a semi-permeable membrane. Um, so the membrane is permeable to water only and not to the solutes. So if your concentration or osmolality of sodium and chloride was higher than the other side, how is water going to move? What's that going to look like? And then I've got some questions for you to consider with that thought experiment. So that's the pattern of inquiry that we're going to be working on this week. I've got some other resources for you to consider. So let me point us back to Canvas for just a moment. Um, there are some really useful ideas associated with the metabolic panel. So this is a space for you to do a little bit more exploration. So there's a basic metabolic panel and a comprehensive metabolic panel. I give some examples of what we talked about in class today. There's a visualization for what is blood serum. And then you can think about that low and high value. So if, for example, you need help on the pattern of inquiry, this is a great resource for that problem. It's really important here to think about standard deviation and how much variation there really is in the population. So that's something for you to consider as well. And then the reference intervals, right? It's really important to think about, well, why, say, for example, are the reference values for a population of males aged 20 to 50 different than a population of females of the same age? Like, why do we see those differences? Again, in an older population, why do we see differences? In a younger population, say, for example, urine creatinine, if we think about an infant versus a child versus an adolescent versus an adult male versus an adult female. And then this is a great opportunity for you to use your skills and analyze the metabolic panel. Um, and then this one I think is just an interesting. So we often detect analytes via absorbance, whether that's the absorbance due to hemoglobin or bilirubin, are measured in different reference ranges. So if we take a look at this figure and think about potential sources of error, um, what's a problem if you're measuring something, say, for example, at 420? Well, we see some overlap here. We'd have to make sure that the absorbance, right, was due to hemolysis versus icterus versus lipemia. So those are some spaces for you to explore. And we have more we're going to do on Thursday. So we've got a challenge problem that we're going to work on together. If you want to take a look at that in advance, you're welcome to do so. That's here. And then our clinical chemistry analytes. This is a good reference for you as you're starting that process of thinking about your pattern of inquiry. So I'm going to pause sharing for just a moment and ask if there are any questions from you all. I think we're in an okay space. So if you want to, please go ahead and get started thinking about the pattern of inquiry. We're going to work on that together on Thursday, as well as our challenge problem. If you haven't had a chance to do so, oh, I meant to share this earlier and I forgot. Let me go back and show. If you go back on Canvas, there is in our first module the information that you're going to need for reading for Chem 432. So for this week, there are a couple that are going to be super useful. So revisit the serum osmolality and osmotic pressure, and then take a look at the hydration and water autoionization. So these three are the new readings for us for this week. If you haven't had a chance to check those out, please do so. I will post our reading quiz on Thursday. And again, everything's always due the following Monday, so you always have essentially a full week to be able to work on the material before it's due. All right, so with that, I'm going to stop our recording.